Thank you very much. I appreciate it. Yeah, I'm not good at reading slides, but I'm really good at talking. And I represent nursing, which I think is a very important aspect of your care long term. It's the nurse's responsibility to sort of pull the pieces together and have them make sense to you. You don't like it? This? Yeah. All right. Okay. So my talk today is just navigating the course of your care. And believe it or not, you are at the helm of that. Long gone are the days where you walk into the doctor's office and he tells you what you have and what you are to do, and you walk out and you go, okay, plain and simple. And the nurse takes your height and weight and your blood pressure. These days, you need to be your own advocate. And that's really what this is about, is understanding the aspects of your disease. And I'm going to try to do this without... So, first thing, think about this. I know there is one new member of this group today. I met her at lunch. But there are others, I'm sure, and will be others in the future. And this group is a very important part of improved outcomes and being able to navigate the course of your care, because there's a lot of wonderful information. I was so impressed with the dietary recommendations. I was like, whoa, in just 5 seconds they came up with this. So there's a lot of good information among you. So networking among you is really important for long term. So think about what you might tell someone you met that was new to the diagnosis or new to your group that would be helpful. This will have meaning later. So the most important thing you're going to do is improve your care through participation. Whoa, what's happening here? Okay, let's get back to this. And through increasing your knowledge, not your knowledge just about the disease, but the knowledge about your unique version and about relationships such as this. So we want to establish an active role in your care. What do I mean by active role? It's participatory. That means you go in and you participate in your care. You don't sit there and wait for someone to tell you what you have and what you need to do. You need to understand. And to do that, you have to talk. This creates a dynamic relationship. That means it's a relationship evolving, on the move. It's not go in for your visit and go out. It's interacting, having a relationship with your healthcare team. And being strategic. And this comes from knowledge. You can't be strategic if you don't understand what you have to work with. And it empowers you. Because one of the things, I've been in this business 41 years. And almost 2 decades in neuroendocrine. And the one thing in oncology that I've learned is that having a cancer diagnosis robs you of that sense of control of your health. All of a sudden, someone gives you a diagnosis that you feel completely powerless to change. But that is not true. And that's where your active participation, your being the head of the helm, is important. What can you do? Increase your knowledge about your disease, just like you're doing today. You're getting a good overview, a most excellent overview of this type of cancer. But carcinoid neuroendocrine is not the only neuroendocrine. They've alluded to pancreatic neuroendocrine, but do you know there are adrenal tumors and thyroid tumors that are not carcinoid? So it's a huge umbrella which you fall under one and the largest aspect of. And I noticed that there's some pancreatic neuroendocrine patients here today. And you're falling in an even smaller group aspect of that umbrella distribution. So you need to understand your unique version. And in carcinoid, having managed carcinoid patients with Dr. Coles for so long, I was sort of in charge of managing symptoms, is that every patient I walk into, regardless of the same diagnosis, and maybe the same burden of disease, meaning how much disease they have in their body that's active, each one of them was truly unique. Not only in how they present, but what helps them, and how they do over time. And a large part of that is how knowledgeable we are in managing each unique version. So investigate treatment and procedure options. We've heard about a lot of unique treatments, but you go to your local oncologist and he doesn't have them. So if that's all that you did, how would you know? That's why these groups are so critical. And that those things are available to everyone, and we're going to talk about that. The other thing that is so helpful is keep a diary. Write down what you're experiencing, both emotionally and physically. So when you go to the doctor and you talk to the nurse, you can mention this. And the doctor and the nurse can review all of that information with you to help better understand how this disease manifests in you. Speak up. Don't be afraid to ask questions. More and more in healthcare, we're learning that as providers, whether it's the physician or the nurse or the nutritionist or the radiologist, that we're also educators. And to help with compliance, to help with the best outcomes, we understand that the patient needs to know what's going on and what to expect. Again, taking notes, I can't emphasize that enough. Writing things down, because you will remember maybe 10% of what you hear today. That's why they've printed out this information so that you can look at it, and every time you review the information, you're going to learn something different that you didn't think you learned before. That's sort of life. The more you do it, the more you know. So this is true too with regards to your health care. And get active. Come here. This is awesome. Being involved. Helping other patients. Being willing to talk to other patients. Let your health care provider know that if anybody wants to talk to somebody who has what they have, you're willing to talk to them. And information on resources. We heard about a lot of things, but there are lots of resources that we can't even begin to discuss today. And hopefully some of them are on the slides, but don't ever underestimate the internet. And we all laugh because some things on the internet are useful and some things are totally worthless. But it's a good starting place to explore information. Pubmed is another very good place to explore information, and just type in Pubmed. So this is only a small fraction of what a team may encompass over time. But you are at the center of it always. And you are the one directing your care, because the bottom line is you have the final say. You can always say no, you can always get up and walk out, and you can become non-compliant. Those are ways in which people profoundly say no. But the bottom line is you don't want to be in that position. What you want to do is have a team. A team that meets your unique needs over time. And I really apologize if there is no nutrition in there, and nutrition is so important. So nutrition is so important, just to re-emphasize that point we heard today. So why this multidisciplinary approach? Because you live a long time. And your disease is not cookie cutter disease. There's not like you start this and you do this and you do this and you do this and then you die. Or you do this and you do this and you survive. You live a very long time with a very unique personality with regard to that long time survival of this disease. And one unique quality is that you become tenacious. You don't give up. You realize you have something that may be greater than your physician's knowledge or your nurse's knowledge, and you become more knowledgeable about your unique disease than they do, and so you need to help direct that. You also are anxious, because how many of you go sit in your oncologist office or your endocrine office, I'm in endocrine oncology, or your gastrointestinal doctor's office, and look around and see people who are far sicker than you. And they're coming in for their chemotherapy, they're coming in for their injections for their immune system, and you keep coming back month after month, year after year, and all of a sudden you don't see those people anymore. and it begins to wear on you, because sometimes we do nothing in your case. We do what we call this watchful waiting. It's not a knee-jerk reaction to always be doing something. It's very strategic, and when a doctor decides to use, as Dr. Odorisio pointed out, we have this algorithm, but it may be evolving over time as knowledge increases about when to apply what. And there are periods of watchful waiting, and those are particularly anxiety producing because you have cancer in your body. And I look around at the age groups. I'm 61, and I remember when cancer diagnosis was a death sentence. And we're moving away from that. We're moving into a chronic disease state. But it's very anxiety producing for you to sit in office. And it's very frustrating when the physician you go to doesn't understand your disease as well as you do. And that's why it's really important to consult a center of excellence. And I can't say this more emphatically. I'm not saying leave your local physician. I'm saying include a center of excellence to your team. Many years ago, when I first started treating neuroendocrine patients with Dr. Coles, they were often misdiagnosed. And what led them finally to a neuroendocrine specialist was the fact that they didn't die. But they didn't get better either with the chemo that was being given because the pathology was incorrect. The strides that we made just in understanding the pathology of this disease is amazing. And hence that, they're looking at the incidence curve, it's trending up. Well, to some degree, we know that that's because we're getting better at accurately diagnosing it. Another part of it was SEER didn't differentiate in the registries. Sometimes they just put small bowel cancer, not neuroendocrine. And many neuroendocrine patients weren't even listed in the early registries because it wasn't thought to be real cancer. And you'll still hear medical people say, but is that a real cancer? And we all know that it is. So the team gives you access to a multidisciplinary team. You go into a center of excellence and they've got the nutritionist that they can pull in because it would be helpful. They've got the pharmacists that can pull in because they're helpful. They've got nursing. They've got interventional radiologists. They've got surgeons that all can review your information. Pathologists who are specialists at neuroendocrine, that they understand the importance of the Ki-67 in carcinoid patients, that not all of you are created equal, so that we get a confident diagnosis. We know exactly who our enemy is, and then we can begin to strategize how we're going to deal with it. Educational opportunities. Most of these centers, employ physicians with lots of experience, dietitians with lots of experience in your unique area. So they are most knowledgeable about what you have, opposed to a general practice that treats every kind of cancer, which is very important to meeting the needs of a community. But when you want to meet the needs of something that's truly unique, you want to go where the experts are and get their opinion on what you have, because tissue is always the issue, we say in oncology, bottom line that guides what we do. We want education. We want to know, what's the best way to manage my symptoms? And this oncologist that you have can work with this team, and this team over time can guide your local care. Not that you have to travel to these centers every time. That's your choice. But really, these centers of excellence are set up as tertiary referrals. That means that we are there to help guide the medical community. And over these years that I've worked in neuroendocrine, I remember when physicians knew very little, the oncologists knew very little about it. When Larry Coles and I came to Moffitt, it was like we were talking a different language. And now Moffitt has become an institute of excellence, just like Mount Sinai. And so these are the people that you want to guide your care over time with your local doc. And if your local doc has a problem with that, then you might have a problem with your local doc. because we know that there's power in numbers. And although you think you're a zebra, you're really part of a much larger herd than you think. So I just throw this in there because I took out some slides because my predecessors today went over some things that I was just going to throw in about the incidence and about the distribution and about the variety of neuroendocrine. But I thought this was telling in that when you look at other GI cancers, ours is the most prevalent. What does that mean? That means ours live the longest. They're around longer to be counted. That's what prevalence means. But there are a lot of us. Myths. You never get depressed because you produce serotonin. Now you laugh, but I remember probably back in 2002 or 3, I was at a patient seminar in Florida, and that was a debatable question at that time, was how much impact does serotonin have on the disease and depression? We've learned a lot that peripheral serotonin may be involved in cancer development and spread, but the neurotransmitter serotonin in the brain has nothing to do with peripheral serotonin. So yes, you get depressed. And yes, you can take an SSRI. And no, it's not going to make things worse. And that's very important to know, because when you live with chronicity of disease, depression is at some point is almost inevitable because of the constant stress and worry. I can't tell, well, what was carcinoid called? Carcinoid means cancer-like. But we know it's cancer, it spreads. If you can control your diarrhea with something as simple as Imodium, or the flushing really doesn't bother you, then why do we need expensive therapies such as somatostatin analogs? And I think my predecessors alluded to this, is that your symptoms of flushing and diarrhea or wheezing are symptoms of a biochemical element of your disease. And the consequences of just treating that symptom of diarrhea and not addressing the biochemical, and the consequences long term, is tremendous, as evident by Dr. Zachary's talk on carcinoid heart disease. In the early days, we saw a lot more of it. We don't now, because these physicians, and they have a gray hair for a reason, because they've not only been around a while, but they've been so busy educating the medical community. There's been an amazing change in the past 20 years in what doctors know about this disease compared to what they knew when I first started. It's transformational in the outcomes in our patients. There weren't patient support groups back then. There wasn't this network of physicians working together. There was a very small network. And I remember Dr. Warner and Dr. Odorizio, and there was Lowell Anthony, and there was my doctor, Dr. Larry Coles. You know, they were the neuroendocrine champions of the medical community and of patients. And we need to address the biochemical disease. So when someone says, well, it's just diarrhea and flushing, you say, no, 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 no. It's not just diarrhea and flushing. This is about a biochemical component of my disease that needs to be addressed. And the last and final myth has always been interesting to me, is that carcinoid does not run in families. Back in, I think it was 2005, I was doing lectures to groups across the country, and I had multiple people come up to me and say, oh, does it, is there a genetic, component to this? And at the time, it was thought that there wasn't. Part of my dissertation was looking at prognostic factors that in families, and I looked at characteristics of my patients at Moffitt. And one thing I noticed was 1.5% had first-degree family relatives with carcinoid. And when I did the pedigree, your 3 generations, I could identify symptoms that may have been carcinoid in other generations and other family members that can no longer speak to this. And patients would come up and say, yes, my brother and my father and my grandfather and, have this. So the National Institute of Health has a study, and it's looking at these families. And they have identified one gene mutation that has been associated with the patients that they have examined. And it's an ongoing study. So if you hear of someone, or you have a family member, a first degree, and you can go online, I think in your packet there's some information on it too, and you think you qualify, by all means, reach out to them. It's very important information, because it's an early exploratory type thing, but we are beginning to learn the molecular aspects of the disease. And that is the new science that's emerging, because eventually it won't be that you have a gastrointestinal carcinoid. It'll be about the type of molecular cancer that you have. It'll all be about the molecular genetics of your disease, not about where it is, because that's how it will be treated. I followed 10 families, and in these 10 families I collected DNA. And just through the talking to these people, and they were across the country, it opened up their minds that maybe their brother or sister who were not sick at all might also fall victim to what they had. And I had several families have family members screened and were diagnosed early with carcinoid. Once we identified a lineage, then it was important for everyone. So I just put that out there. I mean, in the absence of any hard data, just talking and among your family members, if you suspect this, is very important, so that if they have symptoms, they can reach out and have that investigated. See why I don't do a lot of slides. I just talk. My son say, yeah, you just talk, Mom. So things you might not know. I had carcinoid heart disease. I had some things on here, but I took them off. But no one really talked about this. And I thought this was a phenomenal thing when I first started. I would have a patient in the office, and I would be palpating their liver. That's when you press on the liver to kind of feel for the size of it when it's enlarged. And I had a patient literally pass out on my exam table. And I was new, and Dr. Coles was there, and he immediately took out short-acting somatostatin analog and gave it to the patient. And the patient said to me, oh, I could hear you, but I couldn't move anything. It was a brand new patient. She had very advanced disease. So it made me sit up and appreciate what carcinoid crisis is. And then I've seen it in various settings, most often after a procedure. You're particularly vulnerable when you produce and release excessive amounts of these hormones that can cause changes that was talked about in the carcinoid heart lecture. But these are just some of the signs and symptoms of this, and I think it's important for you to know that this is something that can happen. It's something that is treatable, and it's something that you need to be aware of, and your physician and anybody who does any procedures on you need to be aware of, is that you would need short-acting somatostatin analog, and either given sub-Q or by IV. And it can be something as little as getting woozy when you flush too much. But I've had patients have tremendous reactions to emotional stress or to physical activities, and they have to use the short-acting. How many of you are on somatostatin analog that's long-acting? Or Somatuline? How many of you know about the use of short-acting? Most excellent. The dietitian talked to you about triggers in your diet. Well, those can be very common triggers of a crisis. It can be very mild, or it can be something as simple as diarrhea or lightheadedness, or it can be life-threatening. And I've had patients die on OR tables where the anesthesiologist and the surgeon did not think this was such a big deal, that should not have died. So it's important to know about. Food can be common triggers. And what if your trigger is something you love dearly? God forbid they should take wine or chocolate off my list, because those are the things that help me cope with life many times, depending on the time of day. So if I particularly love chocolate and it's a special occasion and I want my favorite chocolate dessert, but I know that it causes horrible symptoms, I want my chocolate dessert. And these are the nursing things that we think about for our patients, because it's about quality of life. It's about helping you learn how to manage your disease so that you can enjoy your life and not have your life revolve around your cancer. Don't let it dictate it. Let you dictate it. So you use short-acting before you eat that chocolate cake. And then you eat every bite, or maybe two. So it's important to understand this, and I know it wasn't gone into, but I wanted you to be aware of it. You should keep a bottle in your refrigerator if you're prone towards having episodes that may be interpreted as a crisis. And that can be, again, something as simple as diarrhea. I have patients who are marathon runners, and they wouldn't be able to run their marathon unless they pre-medicated, because that physical stress, the endurance that it requires would trigger a carcinoid crisis. And then this is just, I thought I took this out, but this is my picture of the carcinoid heart disease, which you went over. And I just want to tell you that this is 100% preventable if serotonin levels are managed properly. And once it's established, it is not reversible, but we can limit the progression. And that's where the use of the current somatostatin analogs and debulking procedures are important to think about. And that it is a biochemical consequence of your disease. The next thing is the biologic agents and cellular pathways. How many of you have heard of these things? And what is the cellular pathway anyway? Do any of you think you can tell me about cellular pathways, what they do, how they work? Well, it's very complex, but I put it on a really simple level. It's like the old days where you had telephone lines, and there was a track of communication. And then there was the operator who farmed out the information where it needed to go. And that's sort of what the nucleus of a cell is. It's the operator. So there's information coming in under normal circumstances that tell a cell what to do and what not to do. And in neuroendocrine, it's a hormonal enzymatic type reaction that sets off a chain of reactions within the cell. And in a cancer situation, it becomes deregulated. It's like an adolescent. It's totally out of control. Somebody needs to turn on the off button, or at least regulate it somehow. And that's what these agents do, is they inhibit. They help regulate some of that activity, that communication to the nucleus, so that cellular behavior is altered in a positive way opposed to a negative way. And many of them impact cellular proliferation. What that means is the dividing of cells. Somatostatin has that effect. mTOR TKIs also do. Angiogenesis and anti-angio, what does that mean? That means blood vessels that are feeding these tumors. These tumors grow, they grow large, the cells grow, they divide quickly, they need a lot of nutrition. And so part of that nutrition comes from a metabolic rate, but also from blood supply. They need a huge blood supply. And so these agents help to reduce the metabolism. I'm getting warm now. I put on everything I have. I've got on more layers. The only thing I didn't put on was my leggings, and I thought about it because my legs are so cold. But anyway, so it helps regulate these things that cancer needs, and that's how it helps. I mean, that's how they work. They kind of deny the cancer all that it needs. It doesn't kill the cancer, but it slows it down enough so that you experience stability. And in the Somatostatin arena, or the somatostatin analog, or lanreotide or Somatostatin, it helps to limit the secretion and release of these hormones that you may be suffering from. It's really not magic. It's really not hard to understand, but it is reversing an abnormality within a cell that has happened because of genetic in the cells, the genes in the cells, mutations. These genes that are supposed to control things have been silenced. Okay, big deal for nursing is symptom management. And the mainstay has been the somatostatin analogs. We also use in oncology a lot of other things like debulking procedures, whether it's hepatic artery embolization or liver debulking, where they actually remove part of the liver and let it regenerate, or radiofrequency ablation, surgical removal of the primary. These are ways in which we also control symptoms by eliminating cells that can be producing the hormone. But when that isn't being considered at that moment, we need to do something to limit the effects of the biochemical element of the disease and slow down the growth. And somatostatin analogs have been used for that for a very long time. Lanreotide, Somatostatin, is the new guy on the block. It is also an injection. There's differences between these two. Somatostatin originally was a short-acting agent. It lasted about 8 to 11 hours, and now the long-acting lasts about 21, 28 days. Some patients have to take it more frequently, and they work by communicating with that cell via a chemical communication. It is a pain in the butt to give. If you think it's a pain in the butt to receive, it is a pain in the butt to give. And here's why. There is a new formulation, and I'm so happy. I'm so happy to be able to talk about it. I'm so happy for the nurses, in that before it was so fragile. Everything you did was specific to mixing that drug and not consistent with what you do. And you've got patients coming in, and you have to put the diluent in just right down the side so it is absorbed completely. Then you let it sit until it's all changed in color, and that color is a very difficult change to assess. And then you're going to swirl it. Not shake it like you want to do, because that's what you do to everything, but swirl it in a very controlled manner. And then you want to draw it up ever so carefully so that it doesn't clump into your syringe. And then once you get it in your syringe, you have to suspend it. And then you got to change the needle, because you don't want to use the same needle, because that one's dull by now going in and out of the rubber. So, and you've got this big needle, and sometimes it's not big enough. And okay, so then the patient's ready, and you hope by the time you stop doing this and you get it into the patient, it hasn't clumped in the bore of your needle. So there are little tricks that we do. One is you never point the needle down. You always point it up so that it doesn't get drawn into there before you need it. And sometimes it's difficult to give, and you have to pull out and re-put it in, and then sometimes you have to pull it out, put a new needle, resuspend it, and give it. So you understand why your nurse looks at you and smiles. They're so happy to see you, and then they go, oh, but I've got to give you your Somatostatin shot. So it is a very difficult drug to deal with, but they've come out with a new and improved version, which I'm grateful for. I was hoping it was going to be a 3-month version, but it's not. It is less viscous, meaning it's not as thick. There's less amount, and the needle's better, so that it is not as difficult to administer, and patients tolerate it better. But when you think about, you've got to have an injection for the rest of your life every month, scar tissue develops, and it gets really hard. And sometimes I've had needles bounce off patients' bottoms because it's so tough and hard, and to find that sweet spot where there's a place to give it. So feel sorry for your nurse too. She's got her own challenges in giving you this shot. Lanreotide or Somatostatin, however you know it as, is different. It doesn't have to be given by a licensed professional. It's not necessarily in the buttock. It is a gel, not something that you have to reconstitute and then a suspension like Sandostatin is. The needle is pretty large. You know, that's when I look at that needle, I think, oh, okay, I'm going to give that to myself in my leg. I don't know if I could do it. You know, when you think about diabetes and the little tiny needle you use and you get over that. But some of the advantages of it over Sandostatin is that you can give it to yourself, or somebody can give it to you. It's a little easier to administer. And in studies, Sandostatin and Somatostatin are pretty equivalent in their control of the symptoms. And as you saw, there's studies coming out looking at it and hopefully lead to its approval for its therapeutic use in controlling growth. So these are very important drugs to use. And so how does your doctor choose one over the other? Well, one's been around a very long time, so they're very comfortable with it. They know what to expect. They know how to deliver it. The nurses have to get over it. You know, they get frequent education to remind them of how to deal with it. But now we have a new product that is an option. And in my practice, it goes like this. If you're using Sandostatin and it's working for you and it's working for us to give it and you're doing well, it isn't broke, not fixing it. If you're not doing well on Sandostatin, we will try the lanreotide Somatostatin formulation because some patients respond to it. There is no research to support this yet, but I think that is something that we may see, that refractory patients to Sandostatin may actually respond better to lanreotide, and that's just my own observation in my own clinic. But it is an option for patients because sometimes our life interferes with our medical care. Patients who live far away from the medical office have to come in every month. Some patients don't drive, and so they have to find someone to drive them. So being able to self-administer meets their need better than coming into the clinic. Some clinics require you to come in for both, but that's not necessarily how it has to be. I was very excited to hear about the new drug that may be in oral form and its role in your disease. And information is becoming available through research as to where it is in its evolution of being approved. So that's an exciting new thing in your disease state. Things I worry about. The somatostatin analogs are not contraindicated. If you have impaired kidney function or liver function, it doesn't mean you can't use it. If you have other comorbidities, it's usually not a problem. But there are things that I look for in my patients, and I keep an eye out, and I just want to go over them so you're aware. It can alter glucose function, the glucose levels, the pancreatic function. So if you're a borderline diabetic or a diabetic, you may notice some changes. The higher the dose, the more likely you are to have some of these things. Thyroid function. If you're borderline or hypothyroid, you may find that you need adjustments in your medication. So thyroid function, you go to an endocrinologist. If you've been stable for 10 years on your current dose of Synthroid or levothyroxine, you pretty much are going to stay there. But when you throw this in the mix, it needs to be followed much more frequently than the usual yearly or 6-month visit. B12 levels. It impairs absorption. Many of these patients on these analogs have also undergone small bowel resection. So they have two problems. They have bile acid problems in terms of their diarrhea, and the other one is they're not absorbing, they've lost the intrinsic factor to utilize the B12 they're consuming. So B12 supplement becomes a key issue, and levels should be monitored about 2 to 3 years out. Normally people get started if they've had a small bowel resection. Signs and symptoms of fat malabsorption. The nutritionist talked to you about that. how that manifests. And I won't go over it. You just had lunch. With some cheese for all of you who have fat malabsorption. Pancreatic enzymes is a godsend for this. Somatostatin analogs can cause this in high doses. Pancreatic neuroendocrine patients who've undergone surgery often have problems with fat malabsorption or oncreon. So this doesn't help it. And pancreatic patients may be on this as well. Some patients who have cardiac conditions may have some increased in rhythm disturbances, and so their cardiologist needs to know that they are on a somatostatin analog. We've seen changes in the EKGs. And gallbladder, the number one side effect of these analogs is gallbladder disease. We often see it on CT early as sludge. What happens is the contractility of the gallbladder is not as rigorous or robust as it should be, and so sludge builds up, stones form. Very few patients have to have their gallbladder removed because of this, but when I've seen them, the patients, they've had hundreds of stones in their gallbladder at the time. But if you're over 50, you probably have had some stones in your gallbladder that are not causing any problems. So we're prone to them as we age. The average age at diagnosis is around 60. This is not helping. So symptoms need to be discussed. Nurses need to ask about it. You need to remind them. The dietitian talked to you about this in terms of having your gallbladder out and how your diet has changed. And if you go to surgery, most good neuroendocrine surgeons will remove your gallbladder if they think you're going to be on somatostatin analogs, because it's preventing a problem down the road. And their feeling is it's the least of the two evils. So there are resources, and these are only a few. But if, like I said, go online, you can find a lot of resources. This group is probably your best resource because it meets regularly. You have each other, you get to know each other, you can call each other. You're going to hear a lot of different things when you go on listservs. A lot of different ways of approaching the same problem. And just because somebody's done well one way does not mean you're going to do well that way. Like I said, I go into room after room and everybody's different, although they're all alike. And so this is where you write things down and you go to your doctor and you discuss it. You may be captain of the ship, but you need to have one leader physician and a lot of resources to help you have the best and optimal outcome. So, remember I told you, think about what you would ask someone new to the group, what would you would tell them? So here's a new person to your group. 55-year-old female with symptoms of diarrhea, diagnosed with IBS, has flushing, never really thought about it because she's menopausal. One day she had severe abdominal pain and went to the ER thinking it's an appendicitis, but it's really a partial obstruction, and they showed disease in her liver. A biopsy was consistent with neuroendocrine. That's all she knows, that she has a carcinoid. And the local oncologist was called in to round, and she was introduced and discharged in his care. She went to his office. He looked at her diagnosis. He knew her case, and he said, okay, I'm going to run some more tests, and I'll see you back. Her friends say they've had friends who have gone to this doctor, and he's very nice, and they're quite happy. But she came here today because she read about it. What would you tell her? What would you tell her? Somebody raise their hand. I'm going to bring this microphone to you, and you're going to tell me what you might tell her. Wrong answer. No, team. Remember, we're a team. We're a team. Your physician can be part of your team, but you also have, yes, centers of excellence that you can go to. And you have a very good one not very far away. So that can address a lot of your problems, and you have access to a wonderful dietitian. I would love to clone her, but we'll get a video of her in its place. What else might you tell someone? The importance of coming and getting to know people, letting people get to know you. Absolutely correct. Anything else? And what has been your experience that you think has been a very important information or experience that you could share? Okay. Personality is really important, and confidence is really important in your relationship with your healthcare team. Absolutely. Absolutely. Being your own advocate is key. Knowledge is power. I think there's a commercial like that. Absolutely. I have patients tell me they have a favorite nurse and they won't let anybody else give them their injections or draw their blood because they know that this person knows what they're doing. So also talking, find out who's really good in that practice and target them. I think that's an excellent pearl you just gave. Absolutely. Ice works better than lidocaine. No, I mean, I do fine needle biopsies of people's thyroid, and ice works better than numbing them with lidocaine. So it is a powerful anesthetizing agent. Yes. Absolutely. You're in for the duration because physicians like this are turning this into a chronic problem, not a terminal problem. That's very good. What she said is, in case you couldn't hear, is that she would refer them to the Carcinoid Foundation. And that's where she went, because they often know more than the physician. So it's a valuable resource. Absolutely. It's been around a long time, hasn't it, Dr. Warner? Dr. Warner and his wife, this is their baby. This was their child, correct? Yep. Anyone else? Well, thank you very much to those that contributed and to those that stayed. You didn't fall asleep after lunch. I thought I was going to come back and everybody would be sleeping. Thank you so much.